day to everybody, and again this afternoon in Jordan, we'll present a new topic. This is a picture of Wadi Rum in Jordan. This is the place where you go through before reaching to Petra, which, as you know, is one of the world wonders, 7 world wonders. The topic for this evening is going to be colloid cysts of the third ventricle. And as usual, we'll take them from the clinical, radiological, operative, and pathological correlation. Colloid cysts were first reported back in 1858 by Wollman, but the first surgery was done by Dandy in 1921. This is some of the colloid cysts as they appear and as they should be excised. They should.
Okay, we've frozen. Just hang on, hang in there.
Hello?
Yes, I can hear. The screen is frozen. Just hang on.
Okay, okay. Because the voice of Professor Ibrahim cannot reach it to me. This is Professor Muhammad Fahmi, Alexandria, Egypt.
Okay, I'm sure he's going to try to get back. I guess his connection's not so good this week. Okay, he'll come back. Come back. This is unusual, and we'll add. I'm sure they're working on it, but this is unusual. This happens, and we'll just edit this out. He should be back shortly. There he is, he's back. Okay, Dr. Abraham.
What happened, John? Did we miss the first few slides?
Okay, yeah, just start where you left off.
Okay, so I was just mentioning about the embryology and the development of the neural plate and crest and so on, and I will take the Rathke's pouch as an example, where there are 2 pouches, one from the primitive gut and one from the neural tissue. They meet together like in this picture here. It's a good example, actually. That's why I'm using this. So neuroectoderm pouch and the Rathke's pouch, which is coming from the primitive gut, and they join together. The remnants, if they remain, they will form a cyst. And that's one of the theories about how we develop the Rathke's pouch. But we can extend this theory that this is the same theory that the colloid cysts are forming by. So people speak about what's the origin of the colloid cyst. The general consensus that this is a neuroepithelium, that is ependyma, but also a strong new theory that this is a non-neuroepithelium that is coming from the foregut or the respiratory tract. So 3 lesions, they have the same origin, they have the same embryology, they have the same cyst lining and the same contents, and they arise from the primitive foregut. That is colloid cyst, Rathke's cyst, and the intergenous cyst, and they all have the ciliated mucin-producing cells. This is important. Myself and my colleague, Dr. Hussam Farsakh, the histopathologist, we reported this to the American Academy of Pathology, which has been published, and we stated that the colloid cyst lining consists of 2 distinct epithelial cell layers. First cell layer, the superficial one, which is EMA positive, and the deep layer one is positive for cytokeratins. So this is the picture, the superficial and the deep layers of the lining of these cysts. And these are the goblet cells inside, positive. They are cytokeratin positive, cytokeratin 7, cytokeratin 19. EMA in the superficial layer is positive. The lower molecular weight cytokeratin is positive. The high molecular weight is positive. These are very important landmarks for these cysts, for the colloid cysts. P53 is usually negative. 63 is usually negative. And cytokeratin 20 is definitely negative. So all the cytokeratins are positive, except for the cytokeratin 20. And this is what we reported to the American Academy of Pathology. Usually the Ki-67 is very low because this is a very, very benign lesion. So in general, colloid cysts are rare. This is 1 colloid per 1 million population, and they constitute 1% of all brain tumors. But look at this. They constitute 10% of all intraventricular masses. That's why we have to know about them, because if you practice in neurosurgery, you'll see lots of intraventricular lesions, and you have to think about it. So there's no sex predominance here. Age is 20 to 40 or more. The youngest reported in literature is a 2-month-old infant. So where do they are located, these lesions? They could be in the supratentorial, like this, and these are reported cases. This is a case from Japan, a recent one, 2019, a supracellular colloid cyst. Again, this paper confirms what I'm saying. The colloid cyst, the Rathke's pouch, and the enterogenesis are of the same origin. Another supracolloid cyst from India, 2014. So nothing, we have to think further. We have to think wide. Not everything in the supracellular region is a pituitary, and it's not a craniopharyngioma, and so on. We have always to think of a wide differential diagnosis. It could be multiple, like this one, still supracellular, supratentorial, but it is multiple. This is from Germany. They could be infratentorial, as this sterofossa prepontine craniocervical junction, and this case of mine in the upper cervical region. And also this case of mine recently, a prepontine lesion, as you can see here. This is the medulla, this is the pons, so this is the prepontine space, the far lateral approach, and we are removing it, and this proved to be a goblet cell positive. And this is the patient before and after surgery, and his post-operative picture. So this is histologically confirmed, a colloid cyst. So what is the commonest site of all these sites that we mentioned? The commonest site is the third ventricle. And in the third ventricle, they love this area, the area so-called anterior superior part of the third ventricle. This is the commonest, followed by this, followed by this. Examples at the foramen of Monroe, occupying the middle part and occupying the whole part. These are cases of mine. So we have to understand the third ventricle if we want to operate on these patients. And this is a 3D of where is the third ventricle in relation to the other structures. So if we take the roof of the third ventricle, which is our concern, and this is the foramen of Monroe, the colloid plexus, underneath the body of the fornix, you have the 2 internal cerebral veins and the tila choroidea and so on. So we need to know this by heart. We need to know the detailed anatomy of that part. And if we listened, if any of the listeners listened to the lecture given by Professor Yazilji the other day, this man is 96 and he was speaking about the anatomy, the importance of the knowledge of anatomy. And I'm asking you to look into yourselves, look into your programs. Do we teach our residents the proper anatomy? I think anatomy should be the major part of our teaching, and it should be the major part of our questioning. And this has been really neglected in so many, many places. So this is the corpus callosum, this is the body of the fornix, and this is where the foramen of Monroe is. This is the tila choroidea of the third ventricle.
Hello? Hello? Hello, John?
Yes,
I cannot hear right now. Is this
that's right.
central?
That's right.
Or
Just wait, okay?
okay.
His connection is not good this week. Looks like he's frozen again. They know there's a problem.
Okay.
He's trying, he'll, okay, go ahead, Dr. Abraham, you stopped again.
Okay, which slide is it this last slide or should I?
Yeah, wherever you left off.
Okay,
You stopped at
so
fornix.
this is the body of the. This is the body of the fornix coming here to give the columns of the fornix. This is the anterior septal vein, anterior commissure. Anterior septal vein will join the vein coming from here, the thalamus striate, to form the internal cerebral vein. Now, if we take that off, you will see this junction. Anterior septal vein joining the thalamus striate vein, which comes and takes tributaries from the anterior, middle, and posterior caudate veins. And this is important to know. The anatomy is very important here. If we look at the ventricle or the brain from above, do a transverse section, you will see the ventricles. And then if we go zoom into this area, you will find here the head of caudate, the body of the caudate. This is here the rostrum of the corpus callosum, forming the floor of the anterior wall, anterior horn of the third ventricle, of the lateral ventricle. And here, of course, is the thalamus. So there's thalamostriate vein joining the septal vein to form the internal cerebral vein, which we don't see here. It is hidden by the body of the fornix. But this vein that you see here is the superior choroidal vein. Again, one has to know the anatomy of the fornix. Fornix comes from two cruri, two crosses, one cross on the right and the left coming from the fibria, which is near the hippocampus structure, and then it goes and they join together with this tenacious attachment, form the body of the fornix, and then it divides into the column of the fornix here and the column of the fornix here. Just ahead of this is the anterior commissure. And if we look here at the foramen of Monro, you just go 1 millimeter here. This is the geno of the internal capsule. So again, it's an important anatomy, important relationship that one has to understand. I find through my career that people underestimate the colloid cyst. Any cyst has been underestimated. This is a cyst that should be respected and should be treated with a great respect. Again, the two cruri of the fornix joining to form the body of the fornix. And you can see the choroid plexus and the choroid fissure here, the foramen of Monro, the rostrum of the corpus callosum, and so on. If you take half of the body of the fornix, then you can see the tila choroidea of the third ventricle, and you can see here the septal vein joining the thalamostriate vein to form the internal cerebral vein. Like this, if you just push this body of the fornix, you will see the tila choroidea. By the way, this is the medial posterior choroidal artery coming from P3 of posterior cerebrum. If you remove them, you can see the junction of the anterior septal vein with the thalamostriate vein. Your colloid cyst is here, so you need to know all this anatomy. You just don't need to puncture the cyst and come out. This is a crime against humanity, and it has been done repeatedly in the past. Septal vein, thalamostriate vein, the superior choroidal vein covered by the choroid plexus. And then here you can see both forming the internal cerebral vein. Again, this is the superior choroidal vein. The tila choroidea, both internal cerebral veins. And this approach has been used in the past by Dr. Apuzzo to reach to the roof of the third ventricle. Now we have to understand the relationship of this colloid cyst with the fornix, and that sometimes between the two leaves of the septum lucidum, you will find the cavum septum lucidum. And sometimes you will have lesions here that they mimic the choroid plexus. Here you can see the fornix, the column of the fornix, complete here, incomplete on the side. And if you study your X-ray, your MRI, you'll see that this colloid cyst is more on this side, on the left side. It is more attached to the column of the fornix on the left side. Here, it is more attached to the column of the fornix on the right. And if you are not careful and you cause a lesion in the fornix, as in this case here, somebody has gone in and caused a left fornix lesion, this will end with permanent memory disturbance, antegrade, retrograde amnesia. And this is important. This should be respected. Here, somebody has caused partial right and complete left, as we said. you need to know the muscular relationship. And the important ones here are the interoceptal vein, the thalamostriate vein from the internal cerebral vein joining to form the vein of Galen with the inferior sagittal sinus and with the vein of Rosenthal. Piece of anatomy that should be known by heart, not just by names. You should know where they are and how to find them and what to do with them. You have to respect them. So this is the venous angle, interoceptal vein, thalamostriate vein with all its tributaries, the internal cerebral vein going to vein of Galen, joining with the inferior sagittal sinus and internal occipital vein, and this is the Rosenthal vein. This picture is from the book of Yazagir. I keep telling people, you cannot read neurosurgery from handbooks. You need to know everything. You need to know anatomy. You don't just need to read something to reply an exam and pass. In this case, you will be given a certificate to kill. It is not important that you pass just like that. You need to know exactly what you are reading. You need to know exactly what to do with these instructions. Look at this beautiful 3D in the book of Yazagir. You will not find it in the notebooks and handbooks that are in the market. They are useless and we actually should make a law that people should not read them, except in the night of the exam for just a revision. Interoceptal vein, thalamostriate vein, internal cerebral vein, the other side forming here coming to the vein of Galen, and here the inferior sagittal sinus, and here vein of Rosenthal, the straight sinus, and the internal occipital veins and the others. So you can see these relations on the MRI. You can see here the thalamostriate, the septal vein, the internal cerebral vein. So study these structures important and see that you are in a close relation with these structures. Don't underestimate the colloid cyst. It is very challenging. It is highly demanding, and only the expert people should do it. Here you can see the relationship with the vessels, as you can see here. So you can, by studying these, you can really know. Here you can see the septal vein and the internal cerebral vein on the MRI, and you can see them here. This paper is very interesting. It shows the relationship between the interoceptal vein and thalamostriate. Should we know this? Yes, of course you should. On this side, this is the normal side. This is presenting the foramen of Monroe. But look here, interoceptal vein joining the thalamostriate. Look here, it is joining it after a distance. So you should know that these are variants and you may face them. Here, it's a long distance. Here, it's a very far long distance. So you need to know all these variations. Neurosurgery is deep. Neurosurgery is not putting a shunt or doing disc surgery. It's much, much deeper than this. Keep telling people, especially young students and young neurosurgeons, please read from textbooks. I have not finished reading Yazagir. These are 6 volumes. I have not finished them. I keep going back to them and reading from them. Every time you read them, you read something new. Of course, you need to update the information by reading some papers here and there from all the journals. You need to know the anatomy from Roten, for example. I'm not giving you names of textbooks. I'm telling you that you should read from textbooks. Please do not read from handbooks. This is for people who do not know, people who just want to pass the exam, and they're like parrots. You ask them questions, they would answer, but they have no idea what they are talking about. I have nothing against Mr. Mark Greenberg. He made his book from his notes that he wrote just in preparation for the exams, but he read from textbooks, and he just accumulated these notebooks for the night of the exam. Don't read from Greenberg as a textbook. What's the natural history of these regions? Of course, they grow, and they can attain a giant size. The giant colloid cyst of the third ventricle from India. Another one, giant one from Canada, with hemorrhage and calcification. But look at this case of mine. So the natural history, that they increase in size. This patient of mine, 20-year-old male patient, came to me 2006 with this. It was mild symptoms. I just follow him up, no hydrocephalus, nothing, and look, 12 years later, it did not change in size. They can actually resolve. This paper, 2006, resolution. 2 years between this and this, it just disappeared. Here another one, regression of these 1.5 years later. And this one also they called it disappearing colloid. 9 years, it disappeared. So the natural history that they increase in size, but also you take case by case. Some cases will stop, they don't grow. Some cases they will even regress. How do they present these cases? They present with the main thing of hydrocephalus, with all its manifestations: headache, vomiting, blurred vision. Look at this here: drop attacks and sudden death. I will come and allude to this extensively. Another presentation is memory disturbance. And the disturbing thing about memory disturbance, that this column of the fornix, they go into the mammillary bodies. They form a major part of our memory circuit. So if you damage the columns of the fornix, it will cause a major problem. I had a patient who was a pilot with this colloid cyst, and he could not tell where he is and what he's doing. So short-term memory is very much affected in these cases. So sudden death. Lots have been written about sudden death in colloid cysts. Let's see. Looking at literature between this period and this period, 1858 and 2018, all the cases presented were 107 cases. Average age, 29 years, equal male and female, and the average cyst size is not much, it's 2 centimeters. So it does not mean that you have to have a large colloid cyst to have a sudden death. These are the reported cases of sudden death, and these are the authors, and this is the journals, and this is the date of publication. The mechanism here is ball and valve theory. People say that if you have a colloid cyst and you bend forward, it is like a pendulum because it has an attachment. It may block the foramen of Monro and cause acute hydrocephalus. But also you can get this if you have a bleeding into the cyst. And this can come from some activity, dancing, jogging, or high blood pressure, or just sudden expansion of the cysts. And look at this. This can happen during flight, during takeoff, during landing, even days after. So we have really to look into how much we are making mistakes by allowing patients to fly when they have an intracranial lesion. So this is a very deep topic. The cardiac relation and the cardiac arrest cause is because you are pressing on the hypothalamus with all the nuclei there, which have the vascular centers, and that can cause sudden release of catecholamines and cardiac arrest. Can they bleed? Yes, they can. Paper from Japan, hemorrhage inside the colloid cyst. Look at this, post-exercise death. This is really disheartening. A man dies after exercise because he had a cyst that had hemorrhage inside. This is a new publication in the world of neurosurgery, 2019, and this is the hemorrhage. This is a small cyst, but because it bled during exercise, it caused acute hydrocephalus, and nobody could save him. From India, this paper, again, this is a very interesting paper. I really enjoyed reading it. It's called Flying with a Colloid Cyst. This was published in India. This is about an Indian patient who was traveling from India to the Middle East, having a job there. He complained of headache. Should I go, should I not? He wanted to go to work in the Middle East, jumped into the airplane, arrested during the flight, and saved in the last minute. Here again, that they can really attain very giant size with calcifications and hemorrhage. So what is the treatment of these colloid cysts? 3 lines: observation, microsurgery, or endoscopy. And whatever you do, observe or microsurgery or endoscopy, this is a challenging lesion to treat. This is really challenging. Observation is for the symptomatic small colloid cysts that are not causing hydrocephalus, so you can follow them by serial imaging, like the case I showed you, been following for 12 years. Surgery. And surgery is the surgical procedures done for these people, either a shunt procedure or a transcortical craniotomy or transcallosal craniotomy. I will speak about shunting procedure. Shunt in the Middle East, shunt in the Arab world, shunt in the underdeveloped countries, third world countries, is a disease. The residents and young neurosurgeons are taught to treat everything with a shunt. And when I show you the examples, your heart will just bleed. Story of a shunt, I call it. Story of a shunt. It's a bad surgery. Look at this, small ones. Obviously, the surgeon who has done this will give you the excuse. He would say, oh, he came as an emergency at 2 o'clock in the morning. My answer to this was, you are not kidding me, man. You can put an external drain, not a shunt. Put an external drain if this was really top emergency, and then refer him to somebody who can do the surgery. Do not put a shunt in the heads of people just simply because you cannot do the surgery. So putting a shunt did not prevent this cyst to increase and cause severe short-term memory disturbance. Look at this here, shunt, and this, again, it grew up and reached to this size. To me, to put a shunt in the head of a patient with a colloid cyst is a crime against humanity. It cannot be explained except by the incompetency of mediocre surgeons who do not know how to treat these cases. Look at this, huge colloid cyst, and they put a shunt. Emergency, life-saving, nonsense. Don't kid us, because we are not kidding. You cannot kid us with this argument. You can kid your residents, but you cannot kid people who are professionals. This should be stopped everywhere. And this is another story. Bilateral shunts. This is really crime. Cyst is there, bilateral shunts. Tumor is there. If this was my boy or girl, if this was your boy or girl, you would not put a shunt, permanent shunt, to treat the colloid cyst. So back to surgery, we have two routes, either transcortical through the cortex, and the place we go is in the sulcus between the superior and middle frontal gyrus, or in the middle frontal gyrus. You go like this, in one of my cases. Here you go interhemispheric, transcallosal, you split the corpus callosum and go into the ventricle. And again, here is one of my cases. So these are the two main approaches, but the concept is the same. For surgery, you have to have complete tumor removal. This is mandatory. And all attempts should be made to achieve this goal. Don't go for puncturing the cyst. Don't lie to your resident and say that we have decompressed this patient. This is not on. So in microneurosurgery, complete resection is defined, and this is, you can read all papers. This is what is complete resection. It is removal of the cyst content and excision of the entire cyst wall. It is not enough to take the contents of the cyst. It is not enough to cauterize the wall of the cyst. You have done no justice for your patient. And if you look at the microsurgical series, it's very extensive. It's been there for so many decades, and they have long-term follow-up. So it is well established. Transcortical examples, as I said, either in the middle frontal gyrus or in the sulcus between both. We go this angle like this. This is sagittal. Again, these are pictures from my cases. Here, as I said, in the sulcus between the superior and middle frontal gyrus, or through the middle frontal gyrus. This is the incision. This is the coronal suture here. Various flaps that you can make. The head position, this is the way you go to reach to your colloid cyst. So you do cortical incision, as I said, in the middle frontal gyrus or in the sulcus between the middle and the superior frontal gyrus. Go through the brain tissue here. You will get into the ventricle, and then from the ventricle you can see the cyst. Aaron Cohen Gadol invented this a new technique of putting this channel so that you will not put retractors, you will just put this inside and then proceed with your excision. Transcallosal is to go through the corpus callosum itself. And you can see here, again, these are pictures from my patients. You can see that the incision in the corpus callosum, which is the major association fiber between both hemispheres, should be small, 1 to maximum 2 centimeters, so that you will avoid causing disconnecting the two hemispheres together. So this is the transcallosal principle. Again, you want to cross the midline. So this is the superior sagittal sinus. You have crossed the midline, open the dura, and then go here You may find no bridging veins, but you may find large bridging veins, and usually you find large bridging veins. I have not seen a case without no bridging veins. Most of them, they will have large bridging veins. So you retract, and then you go, and then you come to the dorsal aspect of the corpus callosum, and you will find these two arteries, the pericallosal, and above them is the callosum marginum. So here you reach to the white structure of the corpus callosum. This is the pericallosal arteries. You separate them, you'll see the white structure. You do your cortical incision, which is small, 1.5 centimeters maximum. And then you get into the cavity of the lateral ventricle, and then you will see where you are. Can you get lost? Oh, yes. Whether transcallosal or transcortical, you can get lost easily. But the landmark for you is the choroid plexus. There is no choroid plexus in the anterior horn of the lateral ventricle. So if you see the choroid plexus, follow it until you reach to the foramen of Monroe. Nothing here anterior to it. So choroid plexus is your landmark. And this is the, as I said, the column of the fornix. So you go through the corpus callosum, you can go right or left. But amazing enough, and most of us have seen this, that whenever you go transcallosal, most of the time you end in the left lateral ventricle. So whether right or left, just the same. And then once you are there in transcallosal, you can go parafornicate. Here you go into the junction here, or toward.
Hello.
We may have frozen again, Muhammad. But
Yeah,
just
yeah.
hang in there. He'll be back.
Yeah. I get this. Yeah.
Hey, Muhammad, would you like to moderate after when he gets back?
To get what?
Would you like to moderate the discussion?
Yes, I will discuss few point with
Yeah, okay. I'll
Professor.
introduce you after he finishes, and then you just lead the discussion, okay?
Okay,
Okay.
no problem.
Okay, great. Thank you. You're the
Thanks.
most senior here, I think. So,
Yes, I am old right now.
oh, great. This is like going on the fly, making it up. You're part of the Egyptian Association, correct?
I am from Alexandria, Egypt, and I am an associate for European Neurosurgical Society. Also, I went in all the days to US with under supervision of Professor Osama Al-Mifti, but this is 30 years back in 1990
Okay.
for skull-based training. Also, I went to Germany on 1997 and 6 with Professor Majid Sameh on Hanover, Germany.
Okay.
Also for cerebellopontine angle training. Last trip for Japan, spending a few months with Professor Kawase. He is a pioneer on skull-based surgery, I guess.
Where is
Is
he at?
Professor Kawase is on Keio University on Tokyo. I think by now he is retiring. Japanese retired from academic on 65 year, I guess.
Oh,
That's right.
It's like Finland.
Okay.
Finland's like that too. It's
Yeah,
compulsory retirement. It's mandatory retirement.
Yes, from academic in
Oh,
Egypt.
academic. But you can just you can still operate, right?
Yes, on private on my clinic in Egypt from academic. Also, it's 60 year. It is younger, 5 years than Japan and Europe, I guess. In US, I think from academic is 70 year, something like this. On USA, from academic career or something, I think it is 70 years.
That I don't know. Here,
Okay.
let me check with Dr. Sabea, see if what's going on here. This is unusually long.
I see.
Let me check with his associate here.
Yeah.
He usually know. Yeah. Okay, this is okay. I just wrote to his associate. Okay, he says to hold on. Good, that's good.
Okay.
Yeah, he's coming back in.
Okay, that's great.
We'll take a coffee break.
It will be longer than this.
This is the online coffee break.
I see.
Dr. Muhammad, how are you? I'm Dr. Sami Khatib from Jordan. I think we met many times in Alexandria with our colleagues, Dr. Yusri
Okay.
Rustom, Abdul Aziz Bilal, Abbas Omar, and
hello, how are you? Dr. Muhammad
I'm,
Fahmi, Zaid من اسكندرية.
yeah, I'm fine. I'm fine. And how is about the situation in Alexandria? I'm almost in daily contact with my colleagues there.
You mean Corona time and the Corona crisis? You mean that's right?
Yeah, the Corona and everything.
I think on the last week, you can say in all Egypt, you can say stationary, not increasing, not decreasing. But I think we are right now on the summit or the second phase of Corona. I am speaking about Egypt, of course. We hope it will be decreasing on the next couple of weeks or so, because right now we are finishing the third month for lockdown or partial lockdown, or whatever you say. We're starting only on the last Saturday.
Excuse me, gentlemen, Dr. Sabeh is back. Excuse me, I'm sorry to interrupt.
Okay, welcome back, Dr.
We'll continue.
Okay. We are with you.
Okay, carry on, Dr. Sabeh.
I don't know what happened, because we usually are okay, so I don't know if the problem is from my side or your side. Anyway, we'll just continue from where we left. We are talking about microneurosurgery. These are some of the authors that published, especially Nesemeni from Finland, and others, of course. This is a paper I cherish by Atul Goel, my friend. Atul Goel from India reported about 105 cases. 93 had surgery. He achieved total excision in 90 out of 93. He had recurrence in 11, and he had to put a shunt in 11. But he did not put shunt up front, and this is my message. Don't put a shunt up front unless you have to. This is from Anil Nanda from the United States, microsurgical excision using the transcallosal approach in 10 cases, and he supports the microneurosurgery. Another paper from the United States about the interhemispheric transcallosal subchoroidal approach. So many approaches for the microsurgery. Again, this is the paper I mentioned by Juha, if you like to call him. 134 patients, transcallosal in all patients, and he had no mortality. So surgery can be done, and surgery you can excise them, and most of the time, rarely you will get any recurrence. Let's see endoscopy. I always keep saying that in the hands of endoscopists lies the future of neurosurgery. We are really living the era of endoscopy, but learning curve is long. We need time, but endoscopy is a very, very useful and interesting way of doing things. And these are some of the papers published about the neuroendoscopy, the number of patients, the follow-up, and the total resection or partial resection. So this is very interesting to read. This paper from Schroeder and Gap from Germany back in 2002, using the endoscopic resection of the colloid cysts very effectively and very successfully. This paper from Journal of Neurosurgery from US, from Mark Swedan. Mark is known author in this field of the colloid cyst, and he published this very interesting paper about the extruded content of the colloid cyst. So he would show you these as examples of extruded thing, and that they would not cause any problem. This paper again by Mark Swedan, going for endoscopic resection of incidental colloid cyst. So the usual teaching that you need hydrocephalus to operate, Mark Swedan and others say that even if you don't have hydrocephalus, you can go transcallosal and remove even those incidental colloid cysts. Why should you go and remove incidental colloid cysts? He published this. He showed this Dutch study and Finnish study and the risk of sudden death from them. And he advocates that we operate on incidental ones. But he also reported that cases could not be removed because they were covered by the fornices. He had recurrences after 9 years, recurrences here after 3 months with progressive growth. So endoscopy or microsurgery, both are good tools. If you are a good microsurgeon, do it. If you are a good endoscopist, do it. This is not a fight between microsurgery and endoscopy. They can combine together and give you very good results. This paper again by endoscopy from Italy, 29 patients. This is a very interesting paper. Operative neurosurgery 2020, very recent one on the long-term outcome of endoscopic. They said, well, look, we have 74 patients. Let's see what did we relieve of the cyst and what happened with the recurrence. So they classified them into 4 grades, 1, 2, 3, and 4. And this is their grading. So if you remove completely, this is grade 1. You leave a small remnant, grade 2. Bigger remnant, grade 3. Large residual, this is grade 4. And they look at the recurrence rate in these cases. Very interesting paper. And their conclusion was that endoscopic resection of the third ventricle without emphasizing complete capsule removal, and this is important, is a good way of doing things with good long-term follow-ups. Mark Swedan again looked at the endoscopic removal of recurrent colloid cysts. Even if they're recurrent, he would go through endoscopy. And he summarized the cases of endoscopy for recurrent colloid cysts. Very interesting paper by Michael Gap, a very famous endoscopist. Long-term results after endoscopy. Look at this conclusion, it's very important. Our results, their results, indicate that endoscopic treatment of colloid cyst is a safe and effective treatment that provides excellent long-term results. But look at this. However, we determined that significant risk for recurrence exists when even small parts of this capsule were left behind. So do not leave parts of the capsule because this is a major cause of recurrence. And he reported this recurrence after 8 years and recurrence after 15 years. That's a gap. So in endoscopy, not like the microneurosurgery series, endoscopy is less in numbers, they don't have long-term follow-ups, and they cannot define what is the extent of resection. There is no consensus of opinion. So let's try to see that anybody compared microneurosurgery and endoscopy. And the question is that debate still exists between which one is better. I don't think that we should remain in that box, which is better. I think we should improve on both because both are good. But how can you compare microsurgery with endoscopy series? Because the numbers are different, the follow-up is different. But let's try. So this is a paper by Robert Spitzler, the famous Robert Spitzler, the famous microneurosurgeon in the States. Robert visited us in Jordan several times. He's retired now. And this is the colloid cysts that they show. Let's see what they said. 55 patients. Some of them had craniotomy, 27. Some of them had endoscopy, 28 patients. And they compared the residual, one in cranial, 2 in endoscopy, shunts in 2, shunts here in 5, infection here 5, here 0. So it appears that endoscopy is better. And he put the Kaplan-Meier curve showing that endoscopy is better. So in his conclusion, he said, compared to the transcallosal craniotomy, neuroendoscopy is safe and effective approach. Finally, I would mention this, again by Michael Gapp, back in 2014. There is a need for meta-analysis comparing results of microsurgery and endoscopy, where both specialties have achieved further developments, so the discussion by far did not end. Michael Gabb again, in recent paper, 2018. Again, his results say that there is a definite risk of recurrence more in the endoscopy series. This is coming from one of the giants of neuroendoscopy. Is there any other methods? So people are trying gamma knife, which to me, I don't prescribe to this thinking at all. Why should anybody think to go for gamma knife unless he has nothing else to do? And this is a paper, Surgical Neurology 2015, about you go and aspirate the cyst stereotactically, and then you give the capsule a gamma knife. I mean, I don't prescribe to any way near to this kind of thinking. Treatment of colloid cyst by the same, you aspirate and then give radiosurgery from USA. Again, I don't agree to this. I don't even subscribe to this. Now I'll go to my series of these colloid cysts. I had 105 patients who were operated upon, but we have lost 11 for follow-up. So we're left with 94 to report. 94 patients, young patients, youngest 15 or 77. Males in my series are more than females. The main presentation, like the others, headache is more, visual symptoms, memory disturbance. Investigations, we investigate them thoroughly, including neuro-ophthalmic, and we do everything from endoscopy for papilledema, optic OCT for the thickness of the optic nerve, and the color blindness and everything. And what we do also is to do Karnofsky performance scale in addition to memory testing. And we found that Karnofsky in our patients, we did not do this in all patients, we only did it in 32 patients. So this is the latter part of the experience. So the Karnofsky performance was rather good. The radiology of these cases, and what I'm going to show is my cases, the radiology of my cases. On CT, most of the time they will appear hyperdense, but they could be either. They usually don't enhance, so hyperdense, and so on CT, but they could be isodense or hypodense. Do they take contrast? Rarely so, but some of them would take, like this one. MRI, T1, hyperintense, most of the time, but it could be hypo or iso. So the message here is they could be either, the three of them, hyper, hypo, or iso. They don't usually enhance, but they can take enhancement, especially peripherally, on CT and on MRI. So this is a case of enhancement, peripheral enhancement. The T2 is hypointense in 80% of patients, but sometimes you'd see this dot, this black dot. This is inspissated contents, and these patients, it's difficult to treat them by endoscopy because it is rather hard to remove, and I'll show you some of the cases. So this is the paper about the dot sign. On CT, on T1, on T2, and on FLAIR, you can see it. It's important because it means either there is calcification or hemorrhage. In either case, you will find that it is really firm, sometimes hard. Look at this case of mine, inspissated giant colloid, 45-year-old male patients. On the FLAIR, they have mixed density. And diffusion study, there is no restriction. This is just one MRI of my cases showing you all the sequences that we mentioned. What about the size of these cysts in my series? So a good chunk of them, 27 of them, they had large diameter, 20 to 30 millimeter or 30 to 40 millimeter. And this is different sizes of the colloid cyst in my series. This is the largest of them, one of the largest in the world, actually. I mean, without hemorrhage, without anything, just being there. Other cases are reported where there is sudden increase in size due to hemorrhage, but this is a genuine a case of no hemorrhage colloid cyst. So again, in the coronal section, different sizes of these cysts, and the sagittal, again, the same thing. Angiography, MRA, MRV are essential. You can see the bowing of the anterior cerebral due to hydrocephalus, and you would see the relationship with the others. You will see the venous relations that we mentioned. Whenever you see a lesion in that area, you have a long list of differential diagnoses. Again, I'll take you through some of my cases, mostly my cases, and see what is the differential diagnosis here. Ependymous cyst. It's very much like a colloid cyst. Colloid cyst. Can anybody think of this as colloid? Think also of choroid. Arachnoid cyst. Epidermoid, dermoid cyst. Pilocytic cytoma, one of my cases. Pilocytic cytoma within the leaflet of the septum lucidum. Isocytoma grade 2 in the leaflets of the septum lucidum, one of my patients. Ependymoma 4. But review these and you'll see that they look the same like colloid cysts. Astrocytoma grade 3. Glioblastoma multiforme, in the same place like where you find the colloid cysts. Oligodendroglioma. Central neurocytoma. Subependymoma. In addition to giant cell astrocytomas, of course. Subependymal giant cell astrocytomas. Choroid plexus papilloma. Craniopharyngioma contained within the third ventricle. As you know, 5% of the craniopharyngioma are just located inside the third ventricle, and they have no connection whatsoever with the cella. Germinomas, yolk sac tumor, sarcoma, one of my patients, PNET, primary neuroectodermal tumor, meningioma, isolated meningioma within the third ventricle, metastasis, cavernoma, within the area where you'll find the colloid cyst, a lymphoma, forgotten disease, aneurysm. You have to have high index of suspicion to remember that aneurysm of the basilar tip can really grow up into that area. Histiocytosis X, love the base of the brain. Sarcoidosis can be anywhere in the central nervous system. Cysticercosis. And this is a paper published by my friend William Caldwell from Salt Lake City about this cysticercosis back in '95. So what the approaches that I used in the 94 cases, I used mainly the transcortical, 80 cases, transcallosal in 14 cases. And all patients, all of them had some degree of preoperative hydrocephalus, but I do not put a shunt. I have never put a shunt up front in the 94 patients. If it is an emergency, you put an external drain. Putting a shunt for colloid cyst, to my mind, humble mind, this is a crime against humanity and should be stopped everywhere. Did we need to put shunts post-operative? Yes, in one. We had done everything, but still, we needed to put a shunt. Shunt is good, but abused in many parts of the world, including the Middle East. So this is a picture where one of my cases, I found the cyst within the leaves of the septum lucidum. I may use the navigation during the surgery, and I always end my surgery by putting external drain to safeguard against developing hydrocephalus and to wash any blood that may develop. I keep it for 2-3 days until I'm sure that there is no developing hydrocephalus and no hemorrhage. Follow-up was extensive, 2 years to 14 years, average is 7.4 years, and the treatment results We had recurrence in 2, but we had no mortality, thanks God. And I'll show you and share with you this one case of recurrence. 30-year-old male patient with this seems to be inspissated, hard kind of content. We removed it. This is post-op, total excision. Recurred 5 years later, but he was asymptomatic, so I waited on him, followed him now for 3 years after the first surgery. So there's nothing there. It's the same size. He's remained asymptomatic. And this is some of these follow-ups during his visits to my clinic. Complications, we have all the complications that you can think of in this kind of surgery. Wound infections, CSF fistula, fever, subdural fluid collection, epilepsy, some pyramidal weakness which was temporary. Remember that the genome of the internal capsule is just 1 millimeter from the foramen of Monroe. And impaired memory in 3, some of the complications, some hemorrhage in the occipital horn, some of the complications of the transcallosal, some venous complication, subdural hygroma, unilateral and bilateral, and subgaleal collection. Some of the illustrative cases before we finish. 27-year-old male patient with this cyst, and this is post-operative. And this is the post-operative, and another case of 31-year-old female patient, pre and post. Again, this 45-year-old patient with this giant one with the inspissated dot that we mentioned before. And this is immediate post-op. I do the MRI the following morning. And this is follow-up 9 years with no recurrence. Microneurosurgery, I think, is a very good tool and remains a very good tool. Though I believe also that neuroendoscopy is a very good tool. A patient, 23-year-old female patient with this tumor, with this colloid cyst, and this is before and after surgery. Another patient with this 22-year-old male patient with this lesion pre and post. This old man came from Yemen, 77-year-old patient. He was offered bilateral shunt. He was very sane and he decided not to take the advice. He came back to us and we did excision and he left home being well. And this is 7 years follow-up. That's before the Yemeni war occurred. Plus I heard from him about 3 years ago. Another patient with this large, with dots inside cyst, causing hydrocephalus, no shunts, nothing. If it is an emergency, we put an external drain. Don't do these shunts for people and try to explain that it was a life-saving emergency, because it cannot be. Actually, putting external drain will take 5 minutes. Shunt will may take about 45 minutes. This patient again here with the external drain that we put for 3 days, and this is 4 years follow-up. This is the lady herself. This is again giant one with post-operative 36-year-old male patient with large cyst and post-operative. And this is the largest of them all, a huge cyst. As I said, this is the largest cyst without hemorrhage, without any extension that we have faced. And this is the pictures, and this is the post-op. And this is 9 years follow-up, being well with no recurrence. Now I'll show you a few videos and we'll be finished. In fact, we should have finished in time if there was no disconnection of this thing. Now, as I said, we also record our operations in 3D, but for the sake of the presentation of this, I'm going to turn it into 2D. This is in the middle frontal gyrus, cortical incision. Again, I'm going to choose certain cuts of the video just to show you certain principle. Here, you can see here that we are coming to the lining of the ventricle, putting the retractors, and then you can see here that we have reached to the ependyma of the ventricle. Of course, the pressure is high, there is hydrocephalus, so you widen it a little bit, reduce your retractors, and then you are up against the cyst. So stop this, because this is what we meant from this video, is to show you the opening of this transcortical surgery. From every video, we'll give a message. Again, here, we don't need to show you the beginning. I need to go out here, show you that we are in now, and we have opened the cyst. You can see it is thick contents. Here when I'm sucking it, still it is suckable. But it's not enough. It's not enough to suck the contents. You need to remove the capsule. So in addition to sucking and taking it out, then you come to the important step of the surgery, and that is to cut the capsule off the column of the fornix, of the choroid plexus, of the anterior septal vein, of the thalamostriate vein. This is the way to do it. Don't cauterize it, cut it, and remove it completely. So this is the last piece. And you can see that we kept the fornix, the column of the fornix intact. So here you are, opening of the foramen of Monroe, saving, and at the end of the surgery, I opened the septum lucidum so that there is communication between the two ventricles. Okay, we'll go for the third one. Again here, this is the picture that you see. Sometimes they have this color, which is very much similar to the column of the fornix, so you have to be careful. Choroid plexus is lying on top of it, so you have to cauterize it. But look, here is the anterior septal vein here, the thalamostriate vein is here. Opening the capsule, the contents are really thick and vicious, kind of very busy, I wanted to say. So look at this cranie. It's very much like the Rathke's pouch cysts or the anterogenous cyst, the same principle that we mentioned. They have the same origin, ciliated goblet cells. Again, removal of the capsule. Do not cauterize. Cauterization will lead to recurrence. Simpson grade 1 in meningioma, don't cauterize. Remove the bone, remove the dura. And this is Simpson grade 1 in colloid cysts, that you have to remove them completely so that you will prevent recurrence. So this is the capsule, and you have to remove it to get a very good result. This is microneurosurgery, and it should be done this way. So this is the last piece, okay? The fourth one. Here you can see that this cyst is really very viscid, extremely viscid kind of cyst. And I'll show you the sucker is not able to take it out. It's really kind of hard, firm, and not suckable at all. Whatever you do, it's just stuck in that place. It's trying to pull it out, it's not coming out. So try all the kind of dissection, but you have to remove it. Here I'm going inside the system, trying to take this very viscid, firm kind of contents. Again, here I'm showing you different kinds of contents of this of the cyst. Okay, I think that's enough just to show you this piece of information. Here, I mentioned that during the presentation, that this was a case where the cyst was in between the leaves of the septum lucidum. So it was not at the foramen of Monro. The foramen of Monro is here. I went backwards and opened one of the leaflets of the septum lucidum and dissected here off the leaflets and off the internal cerebral vein. Same principle, like you're doing a meningioma or acoustic neuroma. Here, because we opened both leaflets, you can actually work in this side of the ventricle, on the right side, and on the left side. The section of this cyst from the surrounding structures here are coming into the medial posterior choroidal vessels, and here is the internal cerebral vein. So just to show you that it can be actually within the leaflets of the septum lucidum. So here is the vein, as you can see. Okay. Last one is, this is the last video to show, I've shown you the transcortical. Now we'll show you the transcallosal, 1 to 1.5 centimeter of incision into the corpus callosum. Here, as we said, we ended on the left side, so we are on the left lateral ventricle. Septal vein is here, thalamus striate is here. So we are pulling this out. It was large, really giant one. Remember that it could be attached to the choroid plexus on both sides. Again, contents are firm, but the technique is the same. So transcortical, transcallosal, each one would give you a certain advantage. Again, here the idea is to remove the cyst as a whole, contents and capsule. If you leave the capsule, this is a code for recurrence. And once there is recurrence, it's usually difficult to treat. With this, I would finish, and I thank you for listening, and I'm happy to answer your comments. I hit your comments and answers. But the conclusion from this presentation, that complete excision is really the aim and the result of these cases. So thank you very much indeed.
Well, thank you very much, Dr. Sabaya. We have a guest moderator here today, Dr. Mohammed Fahmy, neurosurgeon from Alexandria. I'll let him take over. Welcome, Mohammed.
Hello. First, I would like to thank Professor Subeh for his panoramic extra presentation for a colloid cyst.
Thank you.
You take a panoramic view starting from the genetic anatomy, stressing the microneurosurgery, stressing about reading from a textbook on the microneuroanatomy. It would be better to add here is not only reading, should be a training on cadaveric dissection. Is not just to know from a textbook, but also to practice and to know the exact minute relationship. Second, your panoramic view about a different approach and the management. Also, you give a short to the gamma knife. I don't think there is a way for gamma knife and for colloid cyst management. I don't think so. You make a very good comparison between microsurgical removal and endoscopic. Actually, you mentioned a few papers by Professor Gabb.
Yes.
And Professor Gabb, actually I visit him in Greifswald on northeast of Germany. He's a pioneer for cranial endoscopy, rigid cranial endoscopy, you can say. I saw him sometimes, not on colloid cyst, for a large intraventricular supratentorial tumor, removing it by just endoscope with navigation. For me at that time, I think it is 97, like a magic. when you remove a very large tumor from the lateral ventricle diameter about 3 centimeter by just a bare hole to get into to get the endoscope with the help of navigation. For navigation, are you really need for to do surgery with the navigation, microscopic or endoscopic? I understand Professor Gab used the navigation through with the endoscope, but for the open microsurgery, you can see, you can retract. Are you really need a navigation in this regard? This one point.
Right.
Second point about the comparison again between microscopic and the endoscopic. It seems for statistical analysis, the difference is so minimal. And all of us know the learning curve for the endoscopy is a little bit longer than the microsurgery because all of us is accustomed to do a microsurgical operation. I heard lately about the, not a microscope, about the exoscope. It is a new like a microscope, but is easier to learn. Exoscope by using a camera and a display on a large 3D screen. So I feel like there is not a big difference between the endoscope and the microscope, provided that the surgeon is well trained on both. I mean endoscope and the microscope. Thanks, and I will leave the floor after this remark to the other colleague and for you, of course, to answer.
Thank you, Professor Fahmy, and I'm glad to hear your views. Maybe you know, maybe you don't, that I am a graduate from Alexandria University, and so it gives me a great pride to say so. And I think the University of Alexandria has graduated lots of brilliant neurosurgery and neurosurgeons. As far as your question is, no, I don't use navigation except very, very rarely, and I just use it for cases of teaching. And I keep telling my residents that your navigation is your brain and not the navigation machine. So basically, you don't need it during open surgery except for teaching purposes. Thank you for your comments, and say hello to all my colleagues in Alexandria. And one friend of mine who was actually Naib at that time when I was just started my first year in medical school is Dr. Nabil Abdurrahman. I hope he's around and he's in good health. So say hello to all my colleagues in Alexandria University, and thank you for sharing your views.
Okay, Doc, we have a question in the chat from Swatantra Mishra. She asks, what are the recurrence rate in endoscopic and microscopic excision in the largest series?
Yes. It's something like 3 to about 10%. It's more in the endoscopic series than the microsurgical series, but the range is 3 to 10, depending on which center you are dealing with.
Okay, very good. We have another question from Nathalie Gomsi. She's a neurosurgeon from Cameroon, currently in the Ivory Coast. Hi, Nathalie. Well, she asked, thanks, doctor, for the amazing presentation. Please, in the mice surgical approach, what are the indications to use the transcallosal approach over the transcortical?
Right. So the comparison, the question is about comparison, which way to go, transcortical or transcallosal. I personally prefer transcortical. It is less dangerous, as it were, with less complications. Some people will say there is a risk of epilepsy more in the transcortical than in transcallosal. My answer to this is that you have great risk on the anterior cerebral arteries and on the corpus callosum and the transcallosum. So which way I would go? I would study the venogram and would see how much of the veins are there, and then accordingly would choose my way. If there is no bridging veins, I may go transcallosal, but transcortical is very good. The deciding one is the MRV, the venogram, to see the bridging veins.
Very good. Okay, other questions? Go ahead. Does someone have a question? Okay, Ridab, go ahead.
Yeah, Ridab.
You're muted there, Ridab.
Yeah, I hope my voice is clear.
Yes.
Well, thank you, Prof, for the great presentation. It's really well informative and organized. I will make a short question. In the absence of hydrocephalus, would you still go transcortical approach?
The answer is no. Transcallosal is the main indication for those cases where you don't have hydrocephalus. But the question comes immediately, why should you be doing surgery for the small cyst that's not causing hydrocephalus? As I said, I refer to the papers by Sweden, Mark Sweden, who likes to go even for incidental ones without hydrocephalus. I don't prescribe to this. I feel that with the hydrocephalus that's there, it is easy to do the surgery. With no hydrocephalus, to go transcallosal for incidental ones, it's not a good idea.
Okay, Dr. Verliakram, I believe you had a question.
Can I just add,
I'm
you're from Jordan, aren't you?
Yeah, I'm from Jordan, Doctor.
Oh, I'm sorry about that.
And you are one of the first neurosurgeon in Jordan. Am I not right?
Yes, indeed, I am.
John, why I know this fact? I think Ridab and another two ladies are about to graduate, Dr. Kanash, and my daughter, Dr. Asir. So we will have 3 neurosurgeons, female neurosurgeons from Jordan. I'm proud of this because we have to empower females in our countries. We have to give them the chance to proceed, and they have my full support.
Thank you, Prof.
Sorry to interrupt you there. Okay, more comments? Oh, Dr. Verliakram, I believe you had a question. And yes. Dr. Poti, go ahead, Dr. Verliakram.
Hello, Professor Ibrahim Spah. Thank you for your amazing lecture. I have a pre-operative question on how signal intensity on MRI or density on CT scan reflect the density of colloid cyst. Sure. I have a second question on exposure. Even if we do MRV and ongoing transcallosal, we may face bleeding from venous lacunae. So, what's your tips about stopping, about hemostasis, achieving hemostasis? Are you using hemoclip? Are you using bipolar? My last question is how often you add transcolloidal approach to the excision through only the foramen of Monro to colloid cyst? Thank you, Professor.
I've never used, I don't do the transcolloidal one because I don't believe that it adds anything. As I said, the professor, they used to use this in the past to reach to the third ventricle, but Professor, I forgot his name now, to use this technique for to reach to the roof of the third ventricle. As your questions regarding the transcallosal, yes, even if there are no bridging veins, you may have some bleeding, and you have to deal with it the same way. The bleeding is the dangerous one is coming from the pericallosal and callosomarginal rather than from venous sinuses, unless the urotractor is on the spherosagittal sinus causing some tear there. So basically, I love the transcortical much more than I love the transcallosal, but each has its own indications.
Very good. Dr. Poti, go ahead, Dr. Poti, you had a question?
Yeah, thank you. Dr. Poti from VET, South Africa.
Welcome. Yes.
I just want to find out what, in terms of the phonics damage, because I saw your series on complications, you only put one, out of the 94 patients, you only had one memory loss. Does it mean that you only had one phonics damage in your series?
Actually, no. The one I mentioned is the one who had severe memory disturbance, and it got worse after surgery, but then it improved again. I did not have any case of memory disturbance due to fornix, column of the fornix damage at all.
Okay. And then in the well, this is to all panelists. I just want to know, do we know the difference between, in terms of the phonics, when you use an endoscopic approach and a microscopic approach? Because in that paper, they didn't put the phonics damage as a comparison criteria. So I just want to know if someone knows what the incidence of how do you call it, endoscopic approach in terms of the phonics damage, because I find that it's very like your space is quite narrow when you use the endoscopic route. So I just want to know if someone knows what's the incidence of the phonics damage.
Yes, the answer is simple and quick, that the endoscopic one has more chance of having memory disturbances by causing injury to the column of the fornix than in the microneurosurgery. But in the hands of a mediocre surgeon, whether they are endoscopist or microneurosurgeon, you will cause damage to the fornix. And that's why this colloid cyst should be respected and should be done by the most experienced member of the team, whether microneurosurgeon or endoscopist. If you are not experienced enough, whether it's a large space or a small space, you will damage the column of the fornix and cause major problem. But if you look at the statistics, there's more in the endoscopy than in the microsurgery.
Okay, thank you very much, and thank you for your presentation. It was very informative.
Thank you.
Okay, Rapesh Rout, you have a question? Go ahead, Rapesh, and then you're next, Mazen.
Hi, John. Hello, Professor.
Hey, how you doing?
Sir, thank you so much for this yet another wonderful presentation. I have a few questions as always. My first question is there any criteria you follow to decide if you would go with operation or conservative management in your patients, aside from hydrocephalus?
Okay, so the question is, I have a case of colloid cyst, whether I go for observation or for surgery. The answer is very simple. You only observe those cases where they are incidental or they are mildly symptomatic. Mildly symptomatic usually means mild headaches, which are far in between. And this way, I would definitely wait. And I would warn the patient about what are the signs and symptoms that he should come rushing to me if something happens. As I said, the man that I followed for 12 years now, 13 years, it did not change and he remained asymptomatic. So observation is for small, asymptomatic or mildly symptomatic cases.
All right. And what is your protocol for follow-up? How often do you call them for follow-up? And how often do you ask for radiological investigation?
Very good questions. For those I observe, I follow them with 3 months period of MRI. 3 months for 1 year, every 6 months for 2 years, and then every year thereafter. That's if I am observing them. If I have done the surgery and excised them, and as I said, I put external drain for 2-3 days, and then I remove it if there is no hydrocephalus and no blood in the CSF, I follow them with after 6 months and after 1 year, and then I leave it to them whenever they want to report to me.
Right. Thank you so much.
Okay, very good, Mazen. You've been patiently waiting. Go ahead.
Thank you. Great presentation, Dr. Smith, as usual. That was one of my questions about your follow-up protocol. My other question is, what is your preoperative workup? I may have missed it. I missed the beginning of the presentation. Like in terms of CT or MRI or MRV, like what do you do?
Sure. Definitely you need MRI, but sometimes you do CT just to make sure that it is not calcified, etc. But MRI, MRA, MRV for me is just 1 unit. So I always ask for MRI, MRA, MRV is very necessary. And also I ask for ophthalmological opinion to observe my patient before and after, visual fields, optical CT, etc. And we all, those patients, we go for Karnofsky performance scale and memory assessment before surgery and after surgery. It's very important.
And you do that Karnofsky scale, so this way you have a baseline you can compare to.
Karnofsky and memory.
Okay. Did that answer your questions?
Hello,
Basim?
Dr. Subeh.
Go ahead.
Can
go
I
ahead.
talk? Yeah. Hello, Dr. Subeh. This is me, Dr. Muhammad Awad. Brilliant talk as usual. We get used to your very brilliant talks. And I have been honored of working with you one day for 3 months period during the end of 2014. And we learned really a lot of things from you. You were stimulating us to learn anatomy approaches like that. Actually now neurosurgeon practicing in Saudi Arabia. And we have got both facilities. We have got very good microscope, Kinevo, Zeiss microscope, as well as endoscope, Lotta endoscope. Actually, in this Lotta endoscope, the definition of the camera is high resolution HD camera. Besides, we have got the advantage of using two working channels. It's unlike working with only single port working channel. So I operated on just few number of cases of colloid cyst, and I found using two working channels at the same time with endoscope and using this rigid arm fixation, I found it useful in resection of this colloid cyst. Besides using this angled scope to see if there is any remnant cyst after resection and these things. So my question, Professor, do you think this will change the idea that endoscope may have better results in the future if you work with two working channels instead of only one working channel? And just I want from your experience, what do you think? Is it going to change the results for gross total resection of colloid cysts?
Sure. Thank you, Dr. Awad. And as you said, you spent some time with us, yourself and many other of your colleagues, neurosurgeons, male and females from Sudan. I think there's something like 25 or 26 of you who came to us. I'm proud of this, and I'm proud to see you, the ones who came as residents or as fellows, growing to be very efficient neurosurgeons. This really gave me the joy and the happiness to see the result of the teaching. As for your question, definitely there is advancement in microneurosurgery and advancement in the endoscopy. But look at this, and watch my words. Endoscopy is the future of neurosurgery. I think in 20 years' time, endoscopy will take over microneurosurgery. So I always advise that young neurosurgeons, males and females, go for endoscopy training. It's very important. Even if you just keep doing microneurosurgery, endoscopy would help. Assisted microneurosurgery, endoscopy kind of thing. Any developments on the microscope, naive or otherwise, two ports of endoscopy, the rigid microscope, the soft the endoscope, the 3D endoscope, and so on and so forth. It's an addition, and the time is coming where things would explode with this new advancement, and things would improve. Whether endoscopy or microneurosurgery is just the same. Any improvement, any advancement in those fields will give best results for our patients. Thank you for your questions, Dr. Mahmoud, and say hello to all your colleagues.
Assalamu alaikum, sir. It's me, Dr. Adnan. Sir, nice presentation. Once again, as always, excellent presentation, sir. Most of the questions you have responded, sir, which I was thinking to ask. But one of his question is that you have said colloid cyst can present with the different variation on T1. Mostly it's hyperintense in T1, but it can also present with the hypointense and other variation.
Sure.
And the images you have shown that the exact location of colloid cyst where other possibilities can be like pilocytic astrocytomas or other lesions. So you have in your case series you have found any of these other pathologies instead of colloid cyst while operating, or it was the diagnosis of peroperative or post-operative histopathological diagnosis?
Right, Adnan. Thank you for your question. I showed you on the differential diagnosis were my cases, except maybe for one case or two cases, the one on cysticercosis, which my friend William Caldwell reported, but all the others are within my series. So these are the cases that I have faced, and I took them out, and they came with different pathologies. My understanding and my teaching to my young residents is this: you have to have a good list of differential diagnosis for any case you come across. Don't just come across 2 or 3 diagnoses for each location. Don't think of ependymoma and medulloblastoma in the fourth ventricle. Don't think of craniopharyngioma and pituitary tumors in the suprasellar region, and so on and so forth. You have to be prepared, and you have to have this mental exercise which keeps your brain vibrating when you remember all these pathologies. Otherwise, we will forget these pathologies. If you don't think of pathology, it will disappear from our minds. You have to think of TB, you have to think of sarcoidosis, you have to think of that and the other. So have a long list of differential diagnoses, keep memorizing it, keep following them up, and then you will have a very good vibrating mind to know exactly what to do in each of these cases.
Very good. More comments,
Thanks, sir.
questions?
Thanks a lot, sir.
Hi, Professor.
Go ahead. Go ahead.
Hi, Professor. I'm Wael. Thank you. Thank you. This was an elegant and high-level talk as usual, Professor. I have 2 questions. The first one is regarding the transcallosal approach. How to deal with finding a bridging vein? As you said, you will find it about 100 times. How to deal? How can we coagulate it to, or can we sacrifice it to open this corridor and to crease it? As you know, this is a small corridor to operate. The second question, when to predict that colloid cysts will bleed and enlarge from the imaging?
Right. Well, just to ask you about your first question, which vein are you talking about?
The bridging in the corridor of transcallosal approach, you said we will find usually a bridging vein. As you teach us, there is usually no bridging vein between the midfrontal and the posterior frontal vein. So in case we will find it, how to deal with it?
Okay.
Can we sacrifice it?
Sure. Again, thank you, Wael. And Wael, by the way, for those who don't know, Wael has got my surname, so people in Sudan call him Wael Sbeh, which gave me great joy. He was very diligent resident when he came to us. And again, like his fellow Dr. Awad and the others, males and females, they have grown to be very successful, understanding, beautiful neurosurgeons. Well, what we said is that if we usually you find a bridging vein. And the bridging vein for me is just like any artery. I don't sacrifice any vein. What you do is to look at the arachnoid around this vein and dissect it off. And this way you'll get extra length of this vein without the need to sacrifice. Sometimes you need, but don't think of sacrificing any vein unless it is absolutely necessary. Each vein has a function, each vein has a value, so don't coagulate any vein. Now, some of the veins you can get away with it and some of the veins you don't. And if I just mention a few, that the superior petrosal vein or vein of Dandy, some people say don't touch it, some people say, well, I've cut it and nothing happened. The saphenoparietal sinus connection with the middle superficial cerebral vein, the same, you can sacrifice it or not. When you do the frontal approach, you just can sacrifice one of the bridging veins in the frontal area, not more, otherwise you'll get venous infarctions, and so on and so forth. Our knowledge of the anatomy of the heart is much more than our knowledge of the venous, but they are of the same importance. Do not sacrifice anything unless it is of a great necessity.
Okay, very good. Any more questions, comments from the panel? This is a very interactive session, Dr. Savea.
Thank you very much indeed.
That was great. I'm sure the residents got a lot out of it. And I'd like to thank you. Do you have any idea on the presentation next week? Yeah.
Next week, well, I'm going to present the foramen magnum meningiomas.
Very, very good. And once again, thank you very much. And thank you for all the panel for coming. And we'll see you next week.